Well, welcome to Trio Maryland's March Zoom meeting. And I'd like to start the meeting off by saying a hello to all the ladies today and wishing them a happy International Women's Day. We appreciate each and every one of you. I'm Marty Marin, and this is my wife, Michelle, and we manage Trio Maryland. We'd like to welcome all our members and guests this morning, and thank you for attending. Today's topic is U.S. kidney transplantation, present and future. Our next meeting is on Saturday, April 12th, and the topic is creepy viruses and transplant recipients. Always a fun topic. Don't miss out on it. Now, Michelle will introduce our speaker.
Hi, good morning. We are very fortunate today to have today's guest speaker, Dr. Christina Mejia. Dr. Mejia, and I think I'm messing her name up, is an assistant professor of medicine at the Johns Hopkins University School of Medicine. Her areas of clinical expertise include chronic and acute kidney disease and kidney and pancreas transplantation. She completed her general nephrology fellowship at Thomas Jefferson University in Philadelphia, where she served as the chief fellow. She then pursued a fellowship in transplant nephrology at the Johns Hopkins University, after which she joined the faculty. She currently serves as the medical director of the Living Kidney Donor Program and established a low clearance transplant clinic to improve the care of kidney transplant recipients with advanced CKD and allograft. We're very fortunate to have Dr. Christina address the Trio Maryland community. Welcome. Thank you so much for speaking to our group.
Thank you.
Welcome. And I now turn the program over to you.
Good morning, everyone, and thank you to Trio Maryland for inviting me to talk to all of you this morning for National Kidney Month. I hope everybody is having a good Saturday morning. So today I'll be talking about kidney transplantation in the U.S., past, present, and future. I apologize for changing my title a little bit because it was just supposed to be present and future, but I find it quite hard to not give a brief history of kidney transplant just so that you could better appreciate where the field is now and where it is heading. So usually I just start with like a few. I know all of you are probably pretty savvy, but I usually just try to give a quick glossary of the terms that I'll be using, mostly because I tend to jump into like medical terminology. But so when I say it's a transplant candidate, it's the person being evaluated for a kidney transplant. When I say a transplant recipient, it's a person who already received a kidney transplant. Donor, of course, that's who donated the kidney. It's a deceased donor if if the person who donated the kidney passed away. A living donor is a living person who donated the kidney. When I say allograft, it's a transplanted kidney. When I say antibodies, it's like proteins, immunoglobulins produced by your immune cells to fight foreign cells. Antigens are proteins on the cells that are recognized or are the targets of the antibodies. And rejection is a complication when the immune cells fight. So when the antibodies attack antigens, usually in the transplanted organ. And immunosuppression is a state where your immune system is weakened by medication to prevent rejection, or what we call like using anti-rejection medications. Okay. And I know most of you watching are either kidney transplant patients, maybe candidates, loved ones of patients with kidney failure, and maybe some kidney donors too. But in the next 30 to 40 minutes, a lot of what I'll be discussing may not be directly applicable to you. But the way I want you to process it is that all of you are part of the transplant community. Part of your experiences are unique to you. But part of your experiences are also shared with the medical professionals and the thousands of other transplant recipients in the US. So hopefully after this talk, as patients, you can at least get a better context of where your experiences stand in the entire transplant ecosystem. Okay? So just doing a little bit of history, the first kidney transplant was performed at the Brigham Women's Hospital in Boston. It was between identical twins, Richard and Ronald Herrick. Who is Richard, who is Ronald, I would not be able to tell. It was performed by Dr. Murray, who later received the Nobel Prize for Medicine in 1990s for this amazing achievement. Close to a decade after, it was Dr. Paul Terzaki, while working actually as a zoologist in the UCLA, discovered the role of antibodies against the human leukocyte antigen, or HLA, in rejection. This became the foundation of transplant immunology, or how we approach organ transplantation, especially in individuals who, unlike the twins, weren't identical. Dr. Terzaki developed a test to facilitate donor and recipient matching, which is the foundations of what you hear us in the medical field refer to as tissue typing. Another decade passes before some of the common medications for immunosuppression was applied to kidney transplant. So between the 1970s to the 1980s, medications like azathioprine, cyclosporin, and thymoglobulin were introduced and was found to reduce the risk of rejection. So some of the milestones in transplant here in the US are not limited to medical discoveries. One important event was the passing of the National Organ Transplant Act in 1984, which allowed for the government by law to establish a nationwide framework for organ transplant system called the OPTN. This was awarded to the United Network for Organ Sharing, or UNOS, which operates the OPTN. So the NOTA, or became the model of other countries around the world and how their transplant systems work. And then it wasn't until 1990s that the drug tacrolimus became FDA approved for kidney transplant. So a lot of you are probably on this medication. This mainly replaced cyclosporin as part of the standard immunosuppression regimen, and this became the turning point and really resulted in improvements in long-term survival of kidney allografts. In 1995, the first laparoscopic donor nephrectomy for living donors was performed by Dr. Ratner at the Johns Hopkins Baby Hospital. This became a turning point for allowing living donors to donate with less surgical risk and quicker recovery. And then in 2000s, the first kidney paired exchange was performed, what we call commonly as a swap. This I'll be discussing a little bit later, so I'll be alluding it to just circle back to it. But in the deceased donor transplant field, surgeons have also started taking what we call expanded criteria donors. So historically, kidneys needed to be like pretty healthy and young for us to use it for kidney transplant. But this was very limiting and resulted in a lot of wasted organs. If you think about it, people who pass away, they are part of the general population. They have all sorts of illnesses as well, and many of them are on the older side. So what we call as expanded criteria donors, or ECD donors, are kidneys from people who are older than 60 years old or older than 50 years old, but may have things like high blood pressure or an elevated creatinine at the time they pass away. So it doesn't sound too alarming, and studies did show that these kidneys can still be used with good outcomes. And then another decade later, the HOPE Act of 2013 allowed for the use of HIV positive donors to be transplanted in HIV positive recipients. And then hepatitis C, which was previously an untreatable virus that can be transmitted through the blood in organ transplantation, they discovered medications to actually treat this. And this led to our ability to use these kidneys from hepatitis C donors with good outcomes. So all of these changes in the practices of deceased donor transplantation has allowed the transplant community to increase organ transplants in the US. Around 2015, there were also changes in the kidney allocation system that made the allocation of deceased donors a little bit more equitable. So finally, moving to this decade, there were important policies as well. The Advancing American Kidney Health Initiative was signed in 2019, which aims to double the number of kidney transplants in the US, which is a big feat. This initiative rewards the practice of facilitating more home dialysis therapies and transplantations. And then lastly, I think, which is very important, is the passing of the Immunobill in 2020. This took 20 years to pass. And prior to this bill, Medicare only covered for 3 years of immunosuppression, which sounds pretty absurd. As many of you know, that majority of the people with kidney transplant, they require immunosuppression lifelong, which this bill allowed to be covered. So kidney transplant, if you think about it, it's been around for 70 years, close to my mother's age. It's only been around 50 years since the transplant community has really organized itself to have a nationwide framework. And it's only been around like 30 years since we've had our modern immunosuppression comprising of tacrolimus. So just to put it into perspective with other medical milestones, like the first gallbladder surgery was like 140 years ago. Antibiotics was like 100 years ago. Dialysis maybe 80 years ago. So in my opinion, like modern transplant medicine is still a young field, but the advancements that occurred in this period have also been pretty amazing. So at present, we have like 250 transplant centers nationwide divided into regions. All these center data are available to the public. They can be accessed in the SRTR website. So if you want to look up how particular center outcomes are compared to the national average, you could easily look it up. It's pretty transparent. And in 2023 alone, around 28,000 kidney transplants were performed in the US. Around 15,000 of them were from deceased donors, and the rest were from living donors. And I just wanted to highlight that the number of altruistic donors, or what we call non directed living kidney donors, were around like 370. When we say non directed donors, these are living kidney donors who do not know anybody who needs a transplant, but want to come forward voluntarily to just help somebody. That's why for those here in the call who maybe are still waiting for a kidney transplant, one of the most important things is sharing your story to as many people as possible, because there are really good people out there just waiting for an opportunity to help. So more importantly, the number of kidney transplants performed have been increasing through the decades. It increased from around maybe 15,000, sorry, prior to 2010, and to the numbers that we are currently at. We did see, of course, a slight decrease during the height of the pandemic in 2020, but have recovered since then. And of course, it's not only the number of transplants performed that's important, but also outcomes. Based on national data, around 88% of adults who receive a deceased donor kidney transplant are alive with a functioning transplant 3 years after surgery, while around 96% of adults who receive a living donor kidney transplant are alive with a functioning transplant for the same period. And then, based on national data, when we look at graft function, there's around like 70% of deceased donor kidney transplants who achieve a GFR of greater than 30 ml per minute. Sometimes we think of it as 30% function after the first year of transplant. Around 30 to 35% will have excellent function with a GFR of greater than 60 to 90 ml per minute. This is pretty much close to what an average adult and maybe their 70s or 60s would be. And then 80% of living donor transplants have a GFR of greater than 30 as well at the end of the first year of transplant. The risk of rejection is actually pretty low in the first year of transplant, just around like 5 to 10%. And that can be attributed to the modern immunosuppression that we're using. And again, it's nice to see how we progress throughout the years. These graphs look a little bit busy, but basically it shows you the rate of graft failure or graft loss of living donor transplants on the left and deceased donor transplants on the right throughout the years. So each line represents a duration of graft survival, meaning the green line, for example, are kidneys that are 5 to 10 years old. The orange line are kidneys that are 1 to 5 years old. And the blue line are kidneys that are less than 1 year old. So the decreasing slope of all the lines over time suggests that as time passes, we have been getting better and better in managing kidney transplants, and we have been able to improve short and long-term survival of kidney transplants. Simply put, kidneys have been lasting longer and longer throughout the years. And these graphs, on the other hand, reflect patient survival, or how long a patient with a kidney transplant lasts. And what it similarly shows is that throughout the years, patients with a kidney transplant have better short and long-term survival, meaning they live longer as the decades have gone by. So this will be the last slide I show with numbers, but just to drive home the point that we have been doing better. In the 1990s, for example, a deceased donor graft would last for an average of 8 years. This improved to close to 12 years by 2017. For living donor kidneys, the average lifespan was around 12 years, and that improved to close to 20 years by 2017. So how did we get here? And I did mention before in the timeline some milestones in transplant that has molded the field, but I wanted to spend some time to further to just go over some improvements that occurred in different aspects or phases of the kidney transplant ecosystem, from the donor, being a transplant candidate, or immunology technology, care of kidney transplant recipients, and various socioeconomic interventions. So in the donor phase, organ procurement technology has improved, wherein there are better ways to keep the kidneys or organs viable by reducing the time an organ is under conditions that are not close to what's normal. As I mentioned earlier, too, the transplant community has been comfortable using more medically complex living and deceased donors. For example, before, people with high blood pressure were not allowed to become living donors. Now, depending on their age and other conditions, these donors can be considered with proper counseling. In the deceased donor setting, on the other hand, I already alluded to the use of what we call expanded criteria donors, HIV and HCV positive donors. So promotion of living donation has been a big push as well to get to where we are today. One important innovation is the kidney paired exchange program, which I mentioned earlier. It typically occurs when we have a donor and a recipient who are deemed incompatible, usually due to tissue or blood type incompatibility. For example, you have a blood type A person trying to donate to a blood type O patient with kidney failure. This incompatible pair is entered into a paired exchange program registry to try to find another incompatible pair that can facilitate a swap and resulting in two successful transplants. So a lot of innovations have also occurred in the practice of paired exchange itself. So, for example, nowadays we ship living donor kidneys, which allowed exchanges to occur all across the country without the need for donors to travel. For example, a kidney from the West Coast can be shipped to the East Coast instead of a donor like physically going to the East Coast and have their surgery there. There are also ways now for us to facilitate what we call like advanced donation. These are, of course, specific to certain programs that participate in paired exchange programs. But here, a donor can donate ahead of time, maybe due to time constraints, and have some degree of guarantee that the KPD program will try to find a kidney for the recipient later on. And then chains have also been created because of the increase in non-directed donors. What I mentioned earlier as the altruistic donors who just want to donate out of the goodness of their hearts. So unlike a pair, these donors usually start a chain, usually ending with the recipient on the wait list who does not have a living donor. So in around by 2023, around 1,200 kidney transplants were performed through the paired exchange programs. So improvements have occurred as well in how we handle transplant candidates, meaning those who are still in the evaluation phase. So the transplant community has pushed for early referral for transplant evaluation and a push for preemptive kidney transplant, meaning receiving a transplant before a patient with kidney failure ever needs dialysis, because we want to try to avoid any exposure to dialysis. Since chronic kidney disease and cardiovascular disease, they go hand in hand. Better management of cardiovascular risks like hypertension, diabetes, obesity, and hyperlipidemia have helped transplant candidates be suitable for transplant. Immunization, of course, has played a role, as infections, as you know, are a big challenge after transplant when your immune system is weaker. And the same goes for cancer surveillance and management. Previously, certain cancers were barriers to transplantation, but now with early detection, improvement, and treatments, some patients with a history of cancer can now be considered for a kidney transplant. And then our matching system has also become better since the first test that Dr. Terasaki created. We have been also able to do what we call like virtual cross matching, where we can do quick assessments of compatibility which is important for deceased donor offers, wherein quick decisions about accepting a kidney for a certain patient is crucial. And we've also made strides in the post-transplant care. We have been more savvy, despite our limited armamentarium of medications, and still trying to individualize immunosuppression regimens to reduce the toxicity and complications associated with immunosuppression. So now there are some anti-rejection medications that have emerged that try to spare patients from the injury or the nephrotoxicity, kidney injury that results from tacrolimus. Some of you may have had kidney biopsies, wherein it's a procedure that is done, wherein a small sample of your kidney is examined under a microscope. Our colleagues in pathology have become better at understanding what they see and what it means. That has helped us clinicians decide on appropriate treatment, for example, in the setting of rejection or other diseases that can occur in the kidney transplant. The use of biomarkers have also been revolutionary. These are non-invasive ways of potentially monitoring for transplant rejection, usually through a blood test. Usually we use this information in conjunction with markers of kidney function and still sometimes correlated with what we see in the biopsy. And then I know Marty mentioned that this would be the next topic for your next meeting, but we have had better understanding of certain viruses that have caused serious illnesses in our transplant recipients, such as CMV and BK. In the setting of BK nephropathy or BK kidney injury, this can sometimes be a cause of the transplant to fail. As some of you may know as well, kidney disease can come back in the transplanted kidney. So some people who develop kidney failure due to diseases like glomerulonephritis or even diabetes can likely develop the same disease in the transplanted kidney. So some of the knowledge we obtain from our general nephrology colleagues who study native kidney disease, we have applied them in post-transplant care. So you hear the medications like Farxiga on commercials, Ozempic, and things like that, which have been really advantageous for chronic kidney disease in the native kidney in the setting of diabetes, for example. And we have started to apply those knowledge for the care of our transplant patients. And then similar to its impact on transplant candidates, the field of cancer therapy or oncology has made great strides in helping us manage cancer after transplant. As you know, you need a good immune system as well to fight cancers, and certain cancers develop because of a weakened immune system. So just a few more things in the transplant community has been focusing on and have been improving would be improving access to kidney transplant, especially those in more marginalized groups. Improving patient health literacy and awareness. Forums like this have really helped transplant patients understand and become more proactive about their care. The medical professionals, they can only do so much. So usually good collaboration between the patients and the medical professionals usually really lead to good care. The importance of adherence to immunosuppression or taking your immunosuppression as instructed in the appropriate way is always a challenge. People have lives. Sometimes there's a lot of things that interfere with why a patient cannot take or do not take their medication. And different transplant centers and groups have focused on trying to address this, including using technology as well, as this is a very modifiable risk factor for rejection. From an oversight standpoint, transplantation is probably one of the most regulated fields of medicine here in the US, wherein UNOS, the governing body or one that like implements the rules of NOTA, is always breathing down the backs of transplant centers to ensure that transplant is done safely and equitably. So, but of course, despite all these advancements, there's still a lot of patients who are waiting for a kidney transplant. As of February 2024, close to 90,000 patients are still on the wait list waiting for a kidney transplant. From the beginning to the end of 2022, for example, around 18,000 patients were removed from the wait list due to various reasons that made them ineligible to get a transplant. Around 4,500 died while waiting for a kidney transplant, and another 4,500 became too sick to even undergo transplant. So time is really of the essence for people living with kidney failure. And many of you are aware that the wait time for a kidney transplant can be very long. Just by the distribution of blood types in the US, around 50% of AB transplant candidates, or what we call universal recipients, will receive a transplant within 2 years of being listed. But only around 24% of blood type O patients will get a transplant within this period. And usually the wait time for a kidney transplant for O recipients is anywhere from 5 to 6 years. So, where do we go next to address these challenges? A lot of things are going on in the transplant community, but I just selected a few innovations that may have big impacts on the field. I'm no expert in some of these innovations. Many professionals who are way, way smarter than I am are championing them. So I'll just give you some tidbits of information about them. Okay. So as we mentioned, compatibility remains a barrier to kidney transplant or any organ transplant. Some transplant candidates have what we call pre-existing antibodies against HLA antigens. So these are due to sensitizing events or events that expose a person to something that's not part of him or herself, such as pregnancy, having a prior organ transplant, or blood transfusion. So what happens in these settings is that your body remembers these exposures, so that the next time it comes around, your immune system would recognize this exposure and will activate your immune system and will attack it. That's how we usually like fight viruses or certain things that when we've been exposed to it before, our body knows how to fight it. So aside from aiming for kidney paired exchange, which is not always possible, especially in the absence of, for example, a living donor, there are desensitization protocols which exist, such as doing like plasmapheresis or using additional medications at the time of transplant to reduce these antibody levels to facilitate a transplant safely. Clinical trials on additional investigational therapies are on its way, and hopefully this can allow us to facilitate more transplants. Achieving immune tolerance is also one of the holy grails in transplant. The goal of these interventions is to hopefully reduce or eliminate the need for immunosuppression. So one approach is to do a bone marrow transplantation or stem cell transplantation with kidney transplant. So a kidney donor also serves as a bone marrow or a stem cell donor, resulting in the recipient's blood or immune system being a mix of the recipient and donor cells, and kind of recognizes both as part of one person. So that's what we call chimerism. These are only done in a few centers and definitely under research protocols, but definitely is something exciting. Another approach to achieve immune tolerance is doing what we call regulatory cell-based therapy, which is also still just investigational. So think of it as your immune system has certain checks and balances in place, wherein there are some cells that activate the immune system, but there are also other cells that tell your immune system to maybe like calm down, chill out, don't attack, don't keep on attacking something. So the concept behind these cell-based therapies is you infuse specific cells that naturally regulate the immune system to produce tolerance to the kidney allograft. Again, still investigational, but also pretty interesting. And then understanding the impact of genetics has also been very important in the field in transplantation. And the discovery of the APOL1 high risk genes and its association with kidney failure has been at the center. So APOL1 risk genes were protective against a parasite called trypanosoma, which is the cause of African sleeping sickness. So it was evolution's way of having people in Africa adapt to its environment. It is prevalent in West Africa, specifically Nigeria and Ghana, and it can be seen in up to 40% in certain populations and is inherited. So unfortunately, on the flip side, these high-risk variants of the APOL1 gene result in higher risk of kidney failure due to conditions or in the setting of conditions like lupus, HIV-associated kidney disease, or what we call focal segmental glomerulosclerosis or FSGS. And these high-risk variants likely account for the disproportionately higher risk of kidney failure that we see in patients with recent African ancestry. So the Apollo trial is underway, and it aims to determine whether the presence of APOL1 renal risk genotypes in deceased donors is associated with worse allograft survival, if it's associated with more protein or development of protein in the urine, and if it's associated with reduced allograft function in general. And then, if this is found to be the case, then they wanted to identify modifying factors that increase the susceptibility to these poor outcomes. It also aims, one important thing is it also aims to define whether the presence of APOL1 high risk genes is associated with poor kidney outcomes in living kidney donors after they undergo nephrectomy or after they donate their kidney. So, what it aims to do is they obtain APOL1 genetic testing in both deceased and living donor pairs across transplant centers around the US, and then they will correlate them with transplant and donor outcomes. So AI, which you probably are all familiar with, whether you've used it or not sure. I personally haven't used ChatGPT. I don't know how I'm surviving right now, but so obviously I'm not an expert here. But basically, AI allows us to analyze large and multiple data sets to identify patterns and trends. In the setting of transplant, wherein providers and healthcare systems need to make decisions based on large amounts of information, artificial intelligence can be helpful. So, applications that are proposed for AI in the setting of transplant are, for example, in the setting of matching processes, so improve the efficiency of matching, determining organs that can be used and reduce discard rates in a quick manner. So imagine a surgeon trying to sift through all the information about donor offers that come in the middle of the night, and trying to decide quickly about a kidney offer, and making a decision under time pressure. So it can be a lot, and definitely machines can probably be helpful in this situation. Humans have their own limitations. And then it can be also helpful in identifying recipients who are high risk for rejection and allograft failure based on multiple data sets. So if, for example, you combine like data from lab values, their donor history, the matching information, pathology, other markers that go into it, maybe even like socioeconomic factors, all of those can be put together by AI more than what an average person can do, and maybe help us understand which patients are at risks, which patient probably need more attention, and better individualize or predict how each person's transplant journey will be. Overall, AI, we feel, can be used to improve post transplant care, but of course, this is still something to be seen. And then xenotransplantation, of course, all of you are probably familiar with this or have heard this in the news. It's a fast growing field. There has been decades of research in non-human or in the preclinical phase in the past few years, but it has been moving forward quite quickly to actual human application, and xenotransplantation is a reality more faster than what we realized. So why pigs? So it's readily available as we can easily breed them. Their organs are large enough to be suitable for adults. They can also be small enough if we're or made smaller if we're aiming for it for pediatric patients. And they have somewhat of a similar ability to filter and manage electrolytes and toxins like the human kidney. So there are different ways to genetically engineer a pig, but one example is this 10 gene edited pig. This is what was used in UAB, and I believe in NYU as well. So basically, few pig genes are knocked in knocked out or removed. And these genes are the targets of anti-pig antibodies present in humans, and also innate viruses that are in pig cells that we don't want to be transmitted to humans. Additionally, a few human genes are knocked in or added to the pig genotype, and these are human genes that regulate the immune response against the xenoallograft. So basically, you're making the pig less piggy, but more human. So the first few attempts in humans were in it's called the decedent model, wherein the xeno kidney was attached to two brain dead patients. So of course, families of these patients agreed to participate in the study to contribute to science. So if you look at the first two pictures, in on the left, this shows the kidney right after attachment, and then on the middle one, the right side of that, is at 52 hours, and you could see the change in the color, meaning this usually indicates that the kidney is achieving good blood flow and is functioning and filtering, because the kidneys are just their job is to filter blood, right? So when you see it pink up, there's good blood flow there. And then I think the picture on the far right is the kidney actually producing urine. It's connected to a bag that collects the urine. So these experiments lasted for 2 to 3 days. The kidneys achieved GFRs or function maybe between 60 to 100 ml per minute. And these were used to try to understand or study how a xenograft will probably behave in a human being. And then the more recent advancements were actually performing xeno in live humans with kidney failure under FDA approval for compassionate use, meaning FDA just approves it because it's really needed for these patients. And of course, this is still under a study where we could learn a lot about how these experiences would shape the future of xenotransplantation. So there are three patients. I think actually there's now four, but these three are probably the ones you've heard on the news. So I did want to show their pictures because, of course, they're the heroes here in this story, who would eventually shape how we do Xeno later on. So Lisa Pisano, she was the one who had both heart and kidney failure. She received an LVAD, or it's like a heart pumping device, and at the same time a Xeno kidney. And then Rick Slayman was a patient with kidney failure who was having limited dialysis access, and I believe they were having a hard time finding a donor for him. So time was really of the essence for him too, and he received a xenotransplant at Mass Gen. Unfortunately, both Lisa and Rick passed away, but Tuana Looney so far is the longest living patient with a xeno kidney. She was a prior kidney donor and developed kidney failure after complications from pregnancy. She was so sensitized that it was so hard to get a deceased donor for her, and they decided to do a xeno trial for her. I think there is another patient who was just recently done at the Mass Gen, and we're still waiting to hear outcomes or updates from that. So the exciting next steps was that FDA recently approved a clinical trial for xenotransplant, which is expected to start this year. So that would really put xeno in a more, or put the experience of xeno in a more organized and scientific way. But of course, xenotransplantation, despite its successes, of course, have a lot of challenges. It's what you could think of as everybody's just learning along the way too. We don't know how, what the ideal immunosuppression would be. We don't know how the long-term immune response would be, although we have some idea based on preclinical studies or animal studies. We don't know how will the physiology change, meaning will the kidney be able to do the functions of a kidney for a longer period of time, and if there are some nuances that maybe we didn't capture in the preclinical side. And then, of course, infections, that's always a concern. We don't know the extent of the possibility of transmission of infections from a pig to humans. And of course, there's a lot of ethical considerations, and definitely goes into patient selection as well. Which patients should be receiving a xeno? Who asked the pig? So there are a lot of ethics, and again, these are things that we usually discover, or many times more questions just pop up as fast as we get answers to them. And then I'll just spend a few slides on discussing policy, because as we all know, successful government backing goes a long way, as we know with the Immunobill. So one big change that will be happening in transplant centers is the IOTA model, wherein Centers for Medicare and Medicaid Services will be incentivizing centers to increase the number of kidney transplants, increase access to kidney transplant, improve the efficiency of transplant centers and performing transplants. This is very new, and is going to be implemented this year as a trial. And it's we still need to see how this will change the landscape of kidney transplant in the U.S. And then, since living donation is something I'm passionate about, I just wanted to mention a few bills that are being pushed in Congress to help our potential living donors. Sorry. This one is the Living Donor Protection Act. So it prohibits certain insurance carriers from discriminating against and provides other protections for living donors. Specifically, it says that carriers may not deny, cancel, or otherwise impose conditions and policies for life insurance, disability insurance, or long-term care insurance based on an individual's status as a living donor. So they're aiming for federal protections for this. There are different protections on a state level. And then this bill also expresses that recovery from organ donation surgery should constitute a serious health condition that makes it eligible for FMLA. And then the Honor Our Living Donor Act will modify the eligibility for federal financial assistance through the National Living Donor Assistance Center. So this legislation would base eligibility solely on an organ donor's income, rather than the current way where it's based on the recipient's income. Because right now, the way living donor expenses are covered is through the recipient's insurance. So usually, if the recipient's insurance is quite good, but then the donor is like the more disadvantaged financial state, that donor may not qualify for financial assistance. And then the living organ donor tax credit would provide some federal tax credit for out-of-pocket expenses that can be incurred through the process of living donation. And then in the private sector, the American Society of Transplantation created this Living Donor Circle of Excellence, wherein this program helps corporations try to make changes, for example, in their HR policies to be more inclusive or more supportive of people who want to donate. So, in summary, kidney transplant is one of the major milestones in medical and modern medicine. Despite being a young field, many advancements have occurred that had led to improvements in short and long-term allograft and patient survival. But innovations in medicine, technology, and health policy continue to push the field of kidney transplant to new frontiers. So I end with that, and thank you, and I'm happy to answer any questions.
Well, that was great, Dr. Mejia. That's super. Thank you so much. A lot of information. You do have some questions. Carl was asking, is there any information on graft survival time separating out between patients who are adherent to their medication and those who are not?
So that's there would be that's hard to capture like on a national level, but definitely there would be because we wouldn't really like report it like to UNOS, for example, that this patient is like not taking their medications. But definitely there's data on like center level, multi-center level that adherence does affect allograft survival. Usually, it's the late rejection. Those rejections that happens like 5, 10 years after the transplant. Many times that's in the setting of medication non-adherence, and it's not always like the patient's fault. For example, like there are a lot of factors that um, go into what makes you adherent. Like some people, their insurance lapses, or they have other medical illnesses that, for example, that unfortunately they aren't able to focus on taking their anti-rejection medications. You would see a patient who unfortunately needed to take care of their loved ones who was equally sick, forgot to take care of themselves, led to non-adherence. But definitely, the data is clear that non-adherence to medication leads to um, poor allograft survival, and trying to help patients become more adherent is definitely a challenge and something that really a lot of people try to work on.
Thank you. Sharon from Eastern Canada said she hears that patients in the US are not on prednisone for life. Is that true?
So it depends on the centers. So maybe half of the centers in the U.S. Do steroid sparing approach, wherein they taper the steroids, and they may be maintained on two immunosuppression agents like tacrolimus or mycophenolate. Half of the centers are probably using steroids. They taper it to a dose of 5 milligrams of prednisone. It There are some data for either approach. It usually depends on the center's personal experience, in which they are comfortable as well. And at the end of the day, usually it comes to, on an individual level, it comes to a shared decision between the patient and the provider, which weighing the risks and benefits of either approach.
Thank you. Do you have information on sirolimus and the kidney protective properties it has?
Yeah, so I think you're talking about sirolimus. So some patients are on sirolimus in lieu of tacrolimus, for example, or in lieu of mycophenolate. Historically, there were thoughts that maybe it can be protective, for example, for certain viruses, for example, or certain have some anti-cancer effects. So maybe they were preferred in patients who have a lot of viruses or certain cancers. They can be in the right patient. They can be sufficient as an anti-rejection medication. They have their own side effect profiles. So it's usually something that we don't usually start off the bat, but if there's an indication to maybe get you off tacrolimus, we can consider it.
Thank you. Can you say a bit more about the type of cancer patient that might be a candidate for a transplant? You touched on this rather quickly.
Yeah. So for example, like prostate cancers, for example, so depending on the cancer, there's a certain wait time for you to be of it being treated, for example, to be eligible for a transplant. So some of the more like good prognosis cancers, for example, you don't need wait time. Certain skin cancers, for example, are very, very little, like prostate cancers. Certain cancers, the patient needs to be cancer free and in remission for like 5 years. And the reason for that is one, we worry about cancer recurrence. We worry about how immunosuppression modifies your cancer risk or the risk of recurrence. And of course, we worry about like the overall prognosis or survival of a patient, especially when you're dealing with a limited resource. The wait time has changed for certain cancers. So prostate cancer, that changed in the past years. Like before, we were conservative in allowing those cancers to be retransplanted. Now, since some of them we have better knowledge that they're kind of benign, that we're okay with. Kidney cancers, we have been a little bit more liberal with, depending on the stage, of course. Myeloma, there's a lot of changes in the field of myeloma. It's a blood cancer that affects your kidney as well. So before, it's a relapsing disease, or at least it can recur, and it can affect the kidney transplant as well. But with improvements in how myeloma is being treated, now we're able to more comfortably transplant this patient, even if there is a risk of it coming back in the kidney.
Thank you. Carl celebrated 10 years since his transplant. How should he prepare for a probable second transplant when his current kidney declines in function?
So that's a very good question, and like a lot of patients do face your situation, because especially if they were transplanted at a young age, transplants don't last forever. So usually, by the time you would need to have both transplant and chronic kidney disease care, and that's one of the focus I've had in my what I call my low clearance clinic. So one, of course, in general, you want to maintain your overall health. Make sure you're good from a cardiovascular standpoint, you're up to date with your cancer screening, you're seeing your PCP, diabetes controlled, hypertension is controlled, all of those things, to make sure that by the time you need a second transplant, you're healthy, strong enough. So the usual things that you do for health maintenance. And then as your kidney function declines, of course, you want to manage both. You want to manage your immunosuppression, but you want to manage the things that come with chronic kidney disease. So when you're similar to prior to your transplant, you may recall how you were when you were at stage 4 chronic kidney disease, stage 5 chronic kidney disease, and trying to manage the complications of that. And then definitely the most important is trying to get listed early. And that's what we were talking about when we try to aim for preemptive kidney transplant, meaning you want to aim for a kidney transplant before you even see dialysis. So usually you can be referred for a transplant evaluation when your GFR is closer to 20. If you're cleared, you're a good candidate, you can go on the list as early as your GFR is 20, and you start accruing time. So hopefully by the time it's either you have a living donor that when you need another transplant, the living donor is ready, or by the time, if you don't have a living donor, by the time you actually progress to kidney failure, you have accrued enough time on the wait list that you may get transplanted even before you see dialysis. And
Thank you.
definitely maintaining your transplant is of course important still.
Is research still being done with an implantable kidney? I know UCSF was doing research at one time.
Yeah. So they are still doing it. They're still working on the artificial kidney. So the concept of it is basically trying to compress dialysis into like a tiny machine that can be worn or implanted. It They have been making strides. I forgot when they anticipate it, but it won't be decades till they anticipate that it can be something that can be maybe put into like prime time. But they are still working on it, and it is still UCSF.
Thank you. Great presentation. Thank you. Next, what is the difference between Bella infusion and taking tacrolimus orally?
So the belatacept infusion is that's one of what we call like a CNI, or like tacrolimus sparing agent. So the attraction of it is it doesn't have the nephrotoxic effects or the kidney injurious effects of tacrolimus. So some people have been shifted to that. So the advantages of it is avoiding that. So maybe it will result in like lower, better GFRs over time. It can, for some people, avoid the side effects of tacrolimus. Some patients who are intolerant to the side effects, we shift them to belatacept. And then for some people who are adherent, or for example can't achieve like good levels of tacrolimus, eventually it's going to be a once a month infusion that people sometimes are able to better adhere to it. Overall, it really depends on the patient. Like not all patients will qualify for belatacept or should be on belatacept. I think it's a discussion that you'll have with your provider, which would be recommended.
Thank you. Any advocacy for life insurance for transplant patients?
So for transplant patients, not the donor, right? So that I don't know. Personally, I think there's a lot, like kidney transplants, of course, have a lot. Kidney transplant recipients, of course, have a lot of other illnesses too. So definitely, that's something that's challenging. It's the same as any like pre-existing condition. I think the focus is in trying to, at least on the donor side, the assumption is these are healthy people who just don't have one kidney, so they're technically not shouldn't be disadvantaged just because of the surgery that they've had.
Thank you. And the last question, real quick. For those with diabetes, asked to get a kidney and pancreas. I don't know if it's just a statement. And Harold says, thank you for the great information.
Yeah, so there are we still do pancreas and kidney transplants. Those usually the clear indications for it is if you're a type 1 diabetic, you can be evaluated for that. Some type 2 diabetics can also qualify for that. There's advantages and disadvantages, but definitely if you're on dialysis or have kidney failure and you're type 1 diabetic, then many times it's a little bit more straightforward, because you'll be needing immunosuppression for the kidney anyway, might as well for the pancreas. The pancreas alone, it's a little bit debatable nowadays, that just because of how well the glucose, the insulin pumps have been doing.
That's great. Thank you. And Harold added, it helps to be preemptive. So thank
Absolutely.
you, Dr. Christina. This was great information. I think it put everybody in a good place to understand what's going on with kidney transplantation. So we really appreciate your expertise and your time. Thank you.
And we want to thank everyone for attending today. We always love seeing your smiling faces. Don't forget to check out our events page on our website for advance notices for future meetings. Check out our website at www.triomaryland.org. All of our past meetings are posted to our YouTube channel for your convenience. Have a great weekend and enjoy the sunshine.
Super.
Thank
Thank you,
you.
Marty.
Thank you,
Thank you,
everybody.
Michelle.
Charles.
Thank you,
Charles.
Dr. Christina.
Howard, thank you very
Thank you,
much for your
guys.
participation.
Thank you, guys.
And I just want
Thank
to
you,
let you know,
Doctor.
I talked to the xenotransplant recipient Tim. That's why I posted that statement
Right?
the other day, and he is doing great. I know he's just recently gotten out of the hospital and he's home again. So he was unpacking his bag to find his headsets and all that, trying to talk to the group he was with, and we were discussing his situation. And he's starting to share his story more. So you should be seeing him shortly on some video chats.
Well, thanks for sharing that, Howard. I'll watch for that. Thank you.
That's
Have a
great.
good morning.
And a great
Thank
guy.
you.
He's really funny. So he's it's kind of interesting to talk with him.
Might
Oh,
be an
good.
interesting guy to get online with us some weekend.
Good.
Absolutely. Of course, he can't give you stuff, certain things, because it's in the research phase.
Right?
But
Sure.
he's telling you how his life is going and everything, and truly doing well.
I'm sure they'll be cautious with him for a
Oh,
while
yeah.
as they
Yeah.
figure things out. I'm so excited about that. I'm really hoping that that is something that really can take off.
Well, thank you
So
again,
many
Doctor,
patients.
for your time this morning. We appreciate all the information.
Yes, indeed.
And thank you, everyone. Hey, have a great weekend. It's
Take
not
care of yourselves.
super cold this weekend, so it should be
Enjoy,
fun.
enjoy the nice weather coming.
Yep.
Next week. Next week will be nice.
Yes,
Yeah.
it will. Thank you, everybody. Good
See you
seeing
guys.
you all.
Okay,
Good to
bye-bye,
see
y'all.
y'all.